you know, just what an incredible panel to set the tone for these 3 days. What's something that stood out to you a lot? You know, something you learned?
So to me, what really stands out is the extent to which public healthcare programs are just used to siphon funds to private for-profit entities, and how something that might appear on the surface to be in the best interest of everyday working people can be so cynically weaponized to just increase profit for insurance companies and big pharma and other for-profit corporations. I think it's just incredible to get into some of the mechanics of that. And I also was astounded by some of the history of propaganda and things that Ted got into, and how these movements have been so successfully stifled by those who currently get to profit off of it.
Yeah, absolutely. And, you know, I truly appreciate that. And also the, you know, before I went blind, I worked in healthcare for over 10 years. I worked in SHIP. I worked in pre-authorization. I worked in medical assistance. I worked in Medicare. I did all these things. And, you know, hearing, you know, some of what I've gone through actually said, you know, and,
Yeah.
you know, shared with people, it's really good, because a lot of people, you know, just hear the terms and they don't understand all of the red tape and everything that goes on behind that. Each of the guests, each of the panelists will be giving a 10-minute or less kind of breakdown, a summary of what they'd like to discuss. And then each person, I will then ask a question or two pertaining to what they've said. Then we're going to do Q&A and open it up. So I do want to introduce Karen Palmer, PhD. You are a health policy analyst. And I do want you to introduce yourself further as well.
That's me. I actually don't have a PhD. I have graduate degrees in public health. But that's me. I'm in Vancouver, British Columbia, and I'm happy to be with you.
Thank you so much for joining us. And also, Dr. Andy Coates, you are a physician. So can you introduce yourself further, what your specialties are?
So my board specialties are internal medicine and hospice and palliative medicine. I work at an upstate New York level 1 trauma center, and many of my responsibilities revolve around the frail elderly trauma patients these days. But I've also worked in many other capacities, and with some humility, know the delivery system of my own community, several hundred miles in every direction, quite well.
Right. Well, it's going to be really interesting to hear from your perspectives, being actually on the professional side of this. Karen, would you like to start?
Sure. I thought Claudia was going to go first, but I'm happy to go first.
I'm not sure where she is yet.
Okay.
She is having tech issues.
Right.
So I'll go with you first.
All right. So I'm speaking to you from Vancouver, British Columbia, where I am a health policy analyst. And I'm going to just take you through what our healthcare system looks like here, and then some of the threats to it, and some of our visions for what it might look like down the road. So it's kind of hard for me to think of Canada's healthcare system as a radical vision of social justice and healthcare, because it's more like a plain Jane variety healthcare system, just like everywhere else in the developed world, except in the United States. So I think maybe the trouble is that leaders in the US think of it as radical, when universal healthcare is really just the norm in so many places. So I'll tell you a little bit about our healthcare system, what our not so radical vision is for the future of our healthcare system in Canada, and what some of the threats are. So our system works like this. It's called Medicare, just like yours, except it covers everybody, regardless of their age. We have a publicly funded single payer in each of the 10 provinces and 3 territories in Canada that covers all medically necessary hospital and physician services. So that little phrase, medically necessary hospital and physician services, is a bit of a mantra. There are no copays, there's no deductibles, there's no coinsurance for medically necessary hospital and physician care. And to Canadians, this principle of care based on need, not ability to pay, is a defining national value. So doctors decide what's medically necessary, not insurance companies, as we've heard about in the last few talks. Hospitals and physicians deliver care in publicly owned facilities or in private not-for-profit settings, or sometimes in private for-profit investor-owned settings. But doctors are not typically employees of the government, like in the National Health Service, but rather in the United Kingdom, but rather they are usually self-employed, and they are basically independent corporations. And they're paid by the single payer in their province, usually through fee-for-service, but sometimes through capitation, where they receive a set amount per year for each person that's rostered into their care. And then doctors are enrolled in the single payer plans, which is nearly every doctor in Canada, just about, is enrolled. And they bill just one payer in their province, wherever they happen to be practicing. And enrolled doctors aren't allowed to bill patients too, meaning they can't work in what we call dual practice. So they can't bill both the single payer and the patient. And then in some provinces, like in British Columbia, where I am, the earnings of every physician in the province are reported publicly every year in what's called the Blue Book in BC. So for example, I can see that last year my own family doctor billed $245,242 to the single payer. And the highest biller was an ophthalmologist who billed more than $3 million to the single payer. And then hospitals are mostly funded through one annual global budget for each hospital, with most provinces also using some sort of prospective payment or other funding mechanisms. And Canada's healthcare system is tied together by the Federal Canada Health Act of 1984, which says that in each province, in exchange for abiding by 5 principles, the federal government will give that province or the territory their fair share of the federal transfer payment to help pay for Medicare. And it was the enticement of this financial deal with the federal government in 1957 that finally helped spread Medicare across Canada by 1962, after it first began in Saskatchewan in 1946, when the then Premier Tommy Douglas asked Dr. Henry Sigrist, you'll remember him from TED's talk, who was at Johns Hopkins, to review and advise him on the province's health system. And so those 5 principles are that the single payer must be publicly administered, services have to be comprehensive, so all medically necessary hospital and physician services. They have to be universal, meaning everybody in, nobody out. They have to be accessible, meaning on uniform terms and conditions to everyone, so no user fees, no extra billing, no co-payments are allowed. And it has to be portable, meaning that you're covered if you leave your home province and you go to another province, you're covered through a reciprocal billing arrangement if you happen to be temporarily away from your home province and something happens. So then on top of Medicare, most Canadians have some form of private supplemental insurance for the things that aren't covered by Medicare, like prescription drugs that are dispensed outside of hospital, dental care, physical therapy, massage, acupuncture, optometry, glasses, and a host of other things. And so that's the nuts and bolts of how our system works. So what does our vision of an even more just and equitable system look like? Well, adding universal pharmacare is top of the list. Prescription drugs are publicly funded if you're in hospital, but once you're discharged, they're either covered under employer-based insurance if you happen to have that, which many Canadians do, or through private policies or out of pocket. There's been a very big push in the last few years for publicly funded universal pharmacare. And regulating and lowering patented drug prices is a really hot topic right now in Canada, with public consultations actually underway as we speak about how to do that. The next thing is adding universal preventative dental care. Perhaps that's pretty high on the list. It's not covered under Medicare, except if the care also requires hospitalization, so after a traumatic accident, for example. And there are advocacy coalitions pushing to add that, at least for children to start with. When Medicare came into existence, the alternative to national dental insurance was prevention through things like fluoridation and education on oral hygiene and better eating habits, and a focus on dentistry as an individual responsibility rather than a social good. So that's how we ended up with a patchwork of coverage for dental care. The pandemic has also revealed cracks in our mental health care system and in our home care and long-term care systems for older adults, and fixing that too is part of our journey towards healthcare justice. But perhaps most important to our vision of a better Medicare is that we need to integrate the parts of our system with each other so that care processes become more holistically seamless and rather than being siloed. So our challenge is not really about how we pay for care, but rather about how we deliver it. And that's a big thing that people are working on to improve. So the last thing I'll talk about are some threats. And I would say there are three main threats. I would say that the first is that there's a constitutional challenge to British Columbia's Medicare law. A private for-profit investor-owned surgical facility sued the BC government, claiming that British Columbia's Medicare Protection Act, which parallels our federal Canada Health Act, violates British Columbians' constitutional rights to life, liberty, and security of the person, because they say the law does not allow us to pay privately for faster access to care. So the corporate plaintiffs in this case, called Canby Surgeries Corporation, want to strike down British Columbia's Medicare law so that doctors can charge patients more than the public plan pays them in exchange for faster access to care. And they also want to overturn the ban on private duplicative insurance. So as it is now, you can't buy private insurance that copies what's covered under the public plans. So they want what would essentially be private queue jumping insurance for faster access for those who could afford to pay. And lastly, these doctors want to be able to work in dual practice, meaning they want to be able to bill the public plan and patients and private insurers. I would say the second threat on the list of threats is, like in many places, virtual care exploded in Canada within 2 weeks of the World Health Organization declaring the pandemic. Right now, the total capitalization of the digital health market in Canada is around $20 billion. But along with that has come exploitation of inadvertent loopholes in the Canada Health Act. So for example, one virtual care company has decided that it's okay, according to them, to have publicly funded hours during which patients purportedly consult with a general practitioner enrolled in the same provincial plan as where the patients are beneficiaries. But they also have what they call private pay hours, during which patients pay a fee to consult with physicians who aren't enrolled in the public plan where the patients are beneficiaries, but instead are enrolled in the plan of another province or territory. And so this private pay arrangement is new, and it appears to many that it's interprovincial physician dual practice with extra billing and users charges, which is not consistent with the Canada Health Act and in the eyes of many of us. And the third threat, I would say, is the elephant in our living room, which is that our nearest neighbor isn't Denmark, it's the US. Having a more or less free market healthcare system right next door is bleeding into Canada, causing some to agitate for the freedom and choice, we hear those words now, to wreck our healthcare system by changing it from a single payer system to a multi-payer system. So why do I say that the US is influencing how some Canadians think? Well, maybe you heard about the recent, I call it an insurrection in front of our parliament buildings in Ottawa, our nation's capital. It was also called a freedom convoy. And it was a relatively small group of truckers from across Canada, truckers and others, who drove to Ottawa, and they parked a parade of semi-trucks on Ottawa's streets where they demonstrated incessantly for nearly 3 weeks to remove the vaccine requirements at the Canada-US border. But they also demanded that they replace the government with themselves. And they held the city hostage and wouldn't move or stop honking their horns day and night until a very brave 21-year-old woman whose name was Zexi Lee got a lawyer who launched a class action and was granted an injunction to stop the relentless noise. So the protesters blockaded the Ambassador Bridge, disrupting a crucial trade route between our two countries. President Biden got involved. Prime Minister Trudeau eventually had to invoke the Emergency Measures Act for the first time ever. It was awful. There is nothing Canadians hate more than being the center of the world's attention for something so embarrassing. But my point in telling you this is because we heard people yelling to demand their First Amendment rights. Now think about that for just a minute. We don't have a First Amendment to our Constitution. That's your Constitution, not ours. So those protesters were heavily influenced by the same far-right voices that caused your insurrection on January 6th. So all this to say that the sooner the US gets single payer, the happier Canadian neighbors will be, as will every other country trying to fend off the infectious spread of neoliberal policies to one day win healthcare for all. Thanks.
I was saying some really important things too. Bummer. So we're having a panel this weekend on why Medicare for All must be national. However, given the talk you just did, I do want to also ask, what are some of the most common things you hear about Canada's system that you want to debunk when it comes to let's push state by state?
Me?
Yes.
Oh, well, Canada's system unfolded province by province, but I have to say that during this pandemic, I have wished so many times that we had a national health service. We had 13 contact tracing apps being developed, one in every province. There's been lots of times when we've wished that we had a national health service, but we don't. In that sense, it was a provincially implemented system to begin with, but it's a very different story, I think, for the United States, because you already have Medicare. You should just drop the age limit to like 0, like birth.
Yeah, absolutely. And after this, we do have I have an exclusive interview with Larry Sanders, Bernard's brother, who was the healthcare spokesperson for the Green Party in UK, and also a UK gentleman who's a streamer, to explain some issues with the NHS as well. So it's kind of like, is that the ultimate ideal? Yeah, I mean, yeah, for a lot of people, but I think it's so important for people to realize, like, we cannot stop. It's always going to be improvement of whatever we're given at this point. Andy, Dr. Coates, would you like to give your presentation now? And I just want to remind everyone to put comments if you want to ask anything, and then the other Andy will be reading them when he puts them up on the stream.
Yeah, I'd be delighted to speak, and I hope Claudia Fegan joins us, who's a treasured colleague and a great leader. This is very hard because talking to the screen is just very hard. I practice in an acute care hospital, a very big acute care hospital, where the privilege of the position is that there's no one in our society who really escapes the hospital. We all face crucial illness, acute illness, hospitalizable illness. We all die. And when I was soon out of training, I realized that most patients who die in a hospital, and that perhaps I should be comfortable with that process if I were to practice medicine in a hospital. And that led to a board certification in hospice and palliative medicine, but it really was motivated by the social reality that people die in hospitals. And I have now attended many, many deaths. With a little bit of social conscience, you can see that there are hideous inequalities, ridiculous injustices, and so many preventable tragedies. With the consciousness of the health policy on the level of Dr. Malinow or Dr. Woolhandler, and a little bit of the consciousness of the history as given by Ted Brown, it becomes a very vivid, everyday struggle. So on my service, I will have a patient with managed Medicare, maybe United, maybe Humana, maybe WellPoint, doesn't matter. The managed Medicare will deny the patient acute rehab after their trauma, after their hip fracture. because they are protecting their margin. They want to have a profit, and acute rehab is a lot more expensive than subacute rehab, which takes place in a nursing home. There was a time when I was practicing in Troy, and there were patients who had a particular managed Medicare, and there were no rehab options whatsoever because it was a new product and they hadn't made agreements with any facilities. And so therefore the patients that had just signed up with them for their managed Medicare couldn't get to rehab. There are much more shocking injustices in our system. I would think that medical deportations, in other words, someone without documents, an undocumented person who's severely injured or perhaps needs dialysis in the United States, will be sometimes sent home by their hospital in a extra legal deportation to their home country where medical care may or may not be available. The American Medical Association Ethics Committee took this up and reminded physicians that we have an obligation to a safe discharge plan. In other words, it would not be ethical to discharge a patient to another country where death is certain. So the shocking injustices are there. It's not just a scrum about whether or not patients get a little bit better or a little bit worse benefits. The systemic racism is appalling, and I've borne witness many times in many ways, and I have tried my best to change my local institution, to change my community, to change consciousness of my colleagues, but the fact is we are pressing against 400 years of history, and we do not yet have the power to reverse things lickety-split. And so therefore, the witness bearing gets to be incredibly painful, and I'd be glad to talk about that. With respect to what we heard tonight, tonight we heard a lot about the health care delivery system, if you can, the medical delivery system, the medicine and surgery that we all need, and how it gets provided and how it gets paid for, and that's a beginning. But I like to say that although I practice internal medicine, the fact is we all know that health and illness springs from external medicine, the real conditions around us, the social conditions we live in, our resources, our exposures. We're all living downstream these days. And with that consciousness, it should lead to an interest and an understanding in public health. And that's why I believe that this call tonight, if you're listening, I have a very hard time imagining who you are because of the screen, but I would want you to know that this is an essential step for this planet. It will take an incredible mass movement of millions of people to get a little bit of healthcare justice in the United States of America. But if that can happen, it will change the world. It is so important. What we understand is that we all will need help. We will all get sick. We will all die. We will all need the hospital. At some point, we all need the help. And the point about healthcare is that it's not altruism for someone to give you that help. It's basic human solidarity. We, as doctors and nurses and aides at the bedside and pharmacists and social workers and name your allied caregiver, we do this because we know that we will someday be in that bed, that we too would like to be as healthy as we possibly can, that we will need this help. This is a fact of modern life, and it needs to be recognized as a right. It's a very, very important struggle. And it touches on the question of the legitimacy of the people that rule the society. The people that rule our society are under all kinds of threats about their own legitimacy. Sometimes I think it's comical. For example, the neo-fascists rail against the legitimacy of the government as they scream for the power of the government. There's this incredible contradiction, this incredible hypocrisy. Well, of course, the legitimacy that they want is the legitimacy for no one. The libertarian idea that you can go into the woods and come back with your F-150 sucked out of your thumb. No one made it for you. It just appeared. It's an incredibly stupid ideology. It should be laughed at. It's not laughed at. It's actually the official ideology that we all need to be our own selves, our own country. It's silly. The point about healthcare is that this is the future legitimacy of the leadership of society. Health is essential to freedom. Health is essential to life. Health is essential to education. Everyone deserves their best chance at health, and we mean everyone. This is about justice. This is about equity. Health is fundamental, and we must have health. That's a very big question. That's beyond medical delivery systems. That's beyond going to the doctor. That's beyond the emergency room. That has to do with how society is organized so that people are not made sick by their exposures, so that we have reasonable working conditions and working environments, where we live, our water supply. The big question of external medicine is the question of health. And the government, the people that would lead the future of this society, planet Earth, the people that will lead us forward, will gain their legitimacy from emphasizing health and the science that gets us to health. And in that context, with respect to Professor Brown's beautiful presentation, we have seen an incredible onslaught of right-wing activism for 100 years against planning. Never mind socialism, call it planning. We want to have some healthcare planning. We want everyone to have the chance at the best possible healthcare. This is why we invite you, all of you activists, to study the nuts and bolts of this healthcare policy. Because if you understand the policy, you understand how ridiculous it is that we don't have what we should deserve: a dignified health system that's ready for us when we're sick and also wants us to be as healthy as possible at all times. Some of what health policy science teaches us is that user fees, meaning cash when you have to see a doctor or need help, or copays or coinsurance, any kind of cash out of your pocket, discourages people from getting necessary care. This is proven many ways in health policy. It is very bad health policy because science tells us that this discourages people from living longer. So we should do away with all user fees. Middlemen, I sometimes joke that there's no problem in the hospital that more middlemen can't fix. Middlemen are not the answer. We do not need more consultants. We need fewer consultants. We need people to get out of the way of the nurse and the physician at the bedside and stop trying to, quote unquote, gatekeep in the interest of managing the resources. We need caregivers and their patients to make the decisions. And then, most corrosive of all, we cannot have profiteering in medicine. The idea that when someone is sick, it is a time for someone else to make a profit is unethical. It's appalling. It is no way to organize a system. And in fact, when it does organize the system, it cheats the patient out of essential resources. I could say much more. I think I'll stop there. I'm very grateful for this opportunity to participate, and I look forward to hearing Dr. Fegan.
Thank you so much. And you bring up an excellent point about environmental racism. And that is one of the biggest issues of why we need national improved Medicare for all, because it does not matter if you are a citizen or what have you. And we're going to start seeing a lot of, climate refugees and what have you. What is in your practice, do you have a particular story that sticks out to you as someone who could not get the care that they needed and had to leave the US?
So fortunately, in my practice, I have had near encounters with medical deportation, and I'm in a position to suggest maybe that's not what we want to do for this patient. But it has certainly been a fact. One of the things that's interesting about New York is that there are patients who do not have documents who are able to get hemodialysis, which is important, right? So that's a big incremental difference. But what should happen if you went home to your home country? Would you be able to continue your hemodialysis? These are very dramatic, real life, modern problems. In terms of the institutional racism, I have had unbelievably painful experiences where, with my patients' families, I have simply listened and understood that they have been treated in the most undignified, unbelievable way. I don't know if any one story wins more than another, but it's a fact of life in this system that if you're poor and not used to sticking up for yourself in a certain way, you might just wait your turn, and that might turn out to be deadly.
Absolutely. I am going to try to bring Dr. Fegan in. Andy, can we try? Can you hear us, Dr. Fegan? Claudia, can you hear us? Make sure to see if your mute button is on. Okay, unfortunately, it seems like she cannot hear us. So what I want to do at this point, I'm sorry.
I can hear you.
Oh, yay, awesome. Do you want to, we'll just have to not, virtually see you, but we definitely want to hear from you. So can you tell us what you wanted to share with us tonight?
It's utterly frustrating because I missed half of what I missed Andy and Karen's remarks. So I'm not sure what's been said. I enjoyed the previous presentation, but I just wanted to remind folks that the United States is the only industrialized country that doesn't guarantee access to healthcare for everyone who lives here. And we spend more per person on healthcare than anyone else in the world. But it's American arrogance that we believe we have the best healthcare in the world and we can't learn from anyone else. That American exceptionalism. We don't excel in any public health measure compared to any other industrialized country, whether it's life expectancy, infant mortality. I think about maternal mortality, which has quadrupled in the time in which I've been in practice in the U.S. And it's not just embarrassing, it's negligent. And you look at, as a nation, we've never accepted responsibility for the health of our country, as evidenced by our response to COVID-19, where people living in the United States, one of the wealthiest countries in the world, had the greatest risk of death from COVID, that we couldn't figure out why we had greater mortality and morbidity among people of color, because those are the people who have least access to healthcare in the United States. That we spend so much money on excluding people from healthcare. The first thing you see when you go into a healthcare facility in the United States, whether it's a clinic, a hospital, or emergency department, it's the registration desk. And the role of the registration desk, it's determined how will the care be paid for that you're going to receive. And that's the first thing, your first encounter. If you're attending this conference, most people already believe that we already spend enough on healthcare in the United States. We just allow too many people who are not engaged in the delivery of healthcare to take profit from it. And so if we were going to fix it, what should it look like? If we were going to fix healthcare, because I can't really say that we have a healthcare system, but what should it look like? And for so many people, they say, okay, well, fee for service, which used to be quite common in the United States. They say, well, that was the wrong way, because when you pay people for the care that they deliver, that it provides too much of an incentive to deliver too much care. And then we swung the other way and said, well, managed care, that we should, we have capitation, and that we should give health people who are engaged in healthcare delivery a set amount of funds and say, you should deliver the care that's most appropriate. And the incentive there is to deliver too little care, because whatever you don't spend on healthcare, you get to keep in profit. And as a result of that, the United States has never really effectively addressed the question about how do we provide the most care with the funds we have for everyone? When do we accept responsibility for everyone who lives here? And where is it that we have to decide, oh, you're a citizen, and so you're entitled to something more, as opposed to, no, you immigrated here. You know, the late Quentin Young used to say that the problem with the indigenous folks in the United States, the Native Americans, was that they had a poor immigration policy. That we were taken over by folks from other parts of the world who decided they were more entitled to the riches of the country than the people who were here first. And so I take great pride in the fact that I get to be the chief medical officer for a healthcare system in Cook County, which Chicago was part of, where we're able to take care of everyone regardless of their ability to pay. And we don't ask people to prove where they're from or, you know, who they belong to before we decide what care we can deliver. Unfortunately, that is not the model that we have gone with in the United States. It's embarrassing that a country that has so much in terms of resources decides to be so limiting in providing access to care. And we, instead of trying to think about what would improve the health of our population, we have an attitude of, I've got mine, you get yours, and too bad if you're not one of those folks fortunate enough to have access. We, as Andy talked about, the structural racism that exists in the United States today, we act shocked that not providing people the very basics of healthcare. And when I talk about healthcare, I'm not just talking about the medical delivery of medication, but recognizing that healthcare includes safe housing, includes safe food to consume, includes clean air and clean water. It includes having green spaces in which you can exercise and meditate and appreciate the environment around you. We have a very self-absorbed approach to healthcare in the United States. And it means those who have can have, and those who do not have are the have-nots. And oh, well, that's unfortunate, but not our problem. So I don't understand the technical reasons why my camera, which was working all fine all evening, is not working. But I wanted to say that we can do better, that every other country in the world, even poor countries, do better than we do, because at least they acknowledge that they have some responsibility for the people who live within their borders. And I'll stop there.
You bring up some really great points. And I would actually, if you could touch on indigenous peoples more, and basically we see the racism within healthcare, and we see the inequities just across the board. We're going to be doing a panel on that tomorrow. What is, lack of sounding, rudimentary. What is one of the, most common things that you see with health concerns of Indigenous peoples as far as lack of healthcare or lack of sufficient healthcare?
Well, we take from the folks who were living here when the Europeans arrived. We took everything from them, including their land, the resources, their culture. We herded them into small encampments and took everything that was meaningful for them. If they were able to feed themselves on the land, they were able to make a life for themselves, and they had basic needs. And we crammed them into small, narrow spaces and expected them to survive without the resources to feed themselves with adequate nutrition, with all that is taken from people, being the daughter of immigrants. But we have people who have lived impoverished and not had access, learn to subside, or on the very, very minimal nutrition, and then are surprised because they have a greater incidence of diabetes, they have a greater incidence of high blood pressure and cardiovascular disease, because we have not allowed them to have the space, the freedom to access the things that they need to have healthy lives. And then we are demean them and humiliate them and look down upon them because they have these problems, because we have created situations where obesity and diabetes and high blood pressure are the results of the circumstances under which they have survived. So, and then say, well, they should do better for themselves.
Yeah, absolutely. And then we're hearing more and more about food deserts. And I think it's so important that people realize exactly what you said, that is absolutely linked to healthcare as well. Is that something you see a lot where you are in the city?
We see food deserts across the United States, but we see them in certain neighborhoods. And in Chicago, we see them all the time. As a matter of fact, as a part of our health system, we've actually partnered with the food depositories, and our physicians can actually write prescriptions for patients for fresh fruits and vegetables. And we have trucks that come to our clinics on a monthly basis to bring fresh fruits and vegetables. And once all of the patients who have prescriptions for fruits and vegetables have received them, then other people, anyone else from the neighborhood who wants to also receive them can. And so they get a 10-pound package of what's in season in terms of fruits and vegetables, as well as suggestions about preparation. But it's recognizing that we as a country, that healthcare is not just about giving the people prescriptions for a pill, or you have to recognize that we have created systems and that are unsafe and unhealthy, and expect people to thrive in them.
Absolutely. Dr. Coates, did you have something to add?
So we, in my neighborhood, have urban and rural food deserts where the access to fresh fruit and vegetables is questionable on both populations. Poverty, there's been a huge, on the left, there was a big thing about the 1% and the class polarization and how rich the rich had gotten, Whitey on the moon phenomenon. Sorry, but that's a Gil Scott-Heron song. I'm talking about Bezos and the other guy competing to go into space. There's a whole bit of focus on the rich, but in fact, the poor in our country have gotten much more poor. And so if you're worried about the health of your patients, you see the outcome from poverty. And so the question of access to good food supply, which is probably why over the centuries people lived longer, was the food supply increased, You know, I agree with Dr. Fegan that programs that stabilize the food supply are to the credit. But I would say that for activists, for your audience, for tonight, the point is about health outcomes. You know, in the big picture, our country is getting sicker. It's because of the poverty. It's because of these questions like access to good food supply, real jobs that pay reasonable wages. These are health questions. And if we can focus upon the fact that we all need dignified medical services, we can start to enter into that dialogue so that if everyone had access to the necessary care, you think you're having a heart attack, you go to the emergency room, you don't worry about whether or not you're going to be seen. And in fact, you have a well enough planned, I emphasize planned, a planned system so that they expect you, so that they have the personnel to see you in a timely way. They're not doing a just-in-time warehouse. They're not playing a game with profits. They're trying to get ready to see the volume they're going to see, because we looked at last year's statistics and we knew that in our community about this many people are going to come to the ER on Thursday night. And therefore, we're going to process them all within an hour or two. That kind of planning, which we know from science, leads to outcomes. The food question leads to outcomes. The food deserts lead to outcomes. The wait times lead to outcomes. Health activists have science on their side. We all have science on our side to explain that this is unnecessary. We could plan not to have a food desert in the middle of the Adirondacks or in Troy, New York, or in, you know, pick your city, or in the south side of Chicago. We could plan not to do that. We could also plan to be ready for you when you're acutely ill. We have the resources. This is a different vision. And Karen said some amazing things. I mean, she said that it was a defining national value in Canada that people expected there to be a system for them when they got sick. It was a defining national value. I studied history a long time ago, and then when I was a resident, I got a pass to study a little bit of history of the hospital I was at. It was a 1930s hospital. They had an experiment in collective medical practice along the lines of things that both Drs. Woolhandler and Brown touched upon in their history. And that collective experiment was in fact touted by Henry Sigerist, who I got to know very well as a historian. I've read a great deal of his work. The great titan of 20th century medical history is Henry Sigerist, and everyone who wants to know the history of medicine should read Henry Sigerist. Unbelievable accomplishment academically. So when I read that history, I asked for research into the hospital's history, and in the 1930s, I found in the archives of the board of directors letters from a woman who was a farmer, a dairy farmer, and said, I will never be able to pay your hospital bill in early 1930s, but I will send you whatever I can from my milk check every month. And in the archives, she sent a few cents some months. She sent more than $1 a few months. One month she sent more than $2 over the course of the 1930s. And she paid her debt in full by the end of the decade. And the board of trustees of the hospital respected her honesty. And so they memorialized that by keeping it in their archives. What did I take away from that? My patients think that their illness is a shame. They think it's a personal tragedy. They think it's their responsibility. It is not. You did not wish your own illness upon yourself. It happens to all of us. And that incredible ideology that somehow you are to blame for your own illness and therefore must pay to the point of bankruptcy. Within the last year, I had a young woman, her mother had signed over her life savings to her daughter because her daughter was of very meager means, and her mother had, you know, a robust life savings of maybe $10,000, not a huge, a working class life savings. And she wanted that granddaughter to go to college. And that daughter, as her mother had her terminal stroke, was liquidating the $10,000 to do whatever she could for her mother's care. She was forfeiting her mother's life savings because our system had no safety net, despite Medicare, despite hospice care, despite it was going to be a huge cash outlay. And that's sort of a little bit of a story, but the statistics would tell you that in the United States, end-of-life care is provided by the immediate women family members to great financial ruin. And if you think about it the other way, if we had the pride that we all deserve the medical care, the idea that it's a defining national value, that everyone should have it, then it becomes an incredibly liberating idea. I mean, think about, you're trying to organize a trade union for better wages, and all of a sudden you don't have to worry about healthcare for your people. Think about, you're worried about your children and how they're going to make it in their first jobs, and you don't have to worry about healthcare. I'm rambling, I apologize, but
no,
this is what Claudia does.
So I'd like people to think about it, take it to another level in terms of thinking about it, because if like I said, people who are attending this conference, I think, have already accepted the notion that this is something we should do, and we really need to think about, we don't need to just fund the current system because it doesn't serve the needs of the population. We need to have healthcare for people that is directed by the people who are receiving the healthcare. That an effective plan will say, okay, this is, Andy in New York or Claudia in Chicago, these are the dollars that we have, because we recognize that we don't have infinite resources, and we could certainly make better decisions given the funds up front and about how we would spend those dollars, and how you would spend those dollars in South Florida, where you have a lot of seniors who retired there and their needs. It will be different from how you'll spend those dollars on the south side of Chicago or on the west side of Chicago in terms of meeting the needs of the population. But allowing the people who are receiving the care to participate in the planning and the decision-making about what the needs are, and whether the needs are about what we really need is to address the opioid epidemic, or what we really need is to address the fact that there's a food desert, or what we need to do is people don't have space. They don't have green space in which they can be outside and exercise safely without gun violence, or accepting the fact that gun violence is a public health emergency, or accepting the fact that people who don't have stable housing, and at Cook County, we have invested in housing because we recognize that people who have unstable housing get admitted again and again. And that if you provide them with stable housing, they can actually take care of themselves. They don't need you to take care of them, but if they have somewhere that they can lay their head at night, reliably, a place, and they can be out of the elements, that their heart failure doesn't have to decompensate every couple of months, that their diabetes doesn't have to be uncontrolled, but it's putting people in control of their futures, in control of their health. And we make these arrogant decisions that the people don't know what's good for them. People know what they need. People know that the food choices they are making are not the best, but they're making the choices that they can make given what's in front of them. So we have to not only talk about the fact that we're spending enough on healthcare, and we're putting too much of it into the profits of folks who aren't delivering care, but we also have to recognize that we're spending so much on healthcare and not spending it in the ways that would benefit the public the most. This idea that the best thing are bigger and better hospitals is not what the public needs. It's not what will make their health better, and it's not what's going to protect them from serious illness. It's providing the people the opportunity to participate in the decision making and serving their community, and deciding that that small children need a place to play, that adults need decent housing, that they need decent food choices. It's recognizing that healthcare is such an integral part. We didn't have any problem, as Ted Brown talked about, how oh my goodness, we were going to socialize all of the goods, whether it was the water or it's fire or police, but we decided that, we had to stop at healthcare. That that was something that people needed individual choice about. So I think that we really have to think much broader terms about healthcare. And
oops.
You still there, Claudia? Well, I agree. Karen, is there anything you would like to add? I know it's a lot, but I saw you writing a few things down.
No. I'm listening to Andy and Claudia, who I've known for 3 decades, and, reflecting on how many times we've had similar conversations. And, it's easy to feel, I guess, a sense of hopelessness around it all. I mean, I lived in the States for 23 years. I'm very familiar with the circumstances there. But I do think that, that hopelessness, doesn't serve us. I mean, there is so much good energy, at this table this evening, and so much will, and I do think that this is a fight worth fighting. I really do think that.
Absolutely. And, Claudia brings up a really great point that pretty much every single thing that we need is linked to healthcare, be it houselessness or environment or really anything, job creation. It's all linked. Do either of you want to expand on that?
Well, I will just say that, one day I'm going to make a T-shirt that says on one side of it, "What is public health?" and on the other side, it's going to say, "What isn't?" with a big question mark. Because just as,
Take my mind.
just as, I think I could get rich on that T-shirt. That's just really what Andy and Claudia have been talking about. I also think that, I hear from Claudia, 3 words came to mind. That's what I was writing down, and they were purpose, respect, and autonomy. And those 3 words, sort of sum up what most of us want in life. Purpose, respect, and autonomy. And I think that that much of our ability to have those things in our world, has to do with our health. And so it should be sort of at the core. It's the essence of what allows us to, become fully human.
Absolutely. Andy, did you want to add on that?
Yes, thank you. And is Claudia, are you there, Claudia? Can we hear you?
I'm back.
Good.
Because you cut off at an eloquent moment. It was like a mic drop. And then
Can you return to that moment, Claudia?
I think I'm going to need an adult beverage after this.
So if I could, so I think, go ahead, Claudia, sorry.
No, what I was trying to say is that people have to, and Karen got it, they have to have autonomy. They have to be involved in the process. We're too often, especially as physicians, dictating to patients what they need to do, instead of meeting people where they are and allowing them to have some rights of self-determination. People, and Andy, you were right. People don't choose to be ill, but they make the best choices they can with what's in front of them, what's laid out in front of them. And what we fail to do as a society is give them the opportunity to make decisions and give them more choices, right? To allow them to be in charge of what is going to sustain them. And it's offensive that we dictate to folks in this way, and we demean them by telling them they don't know what's best for them, when if they had the opportunity, they would make the choices that would allow them to sustain themselves. And I'll stop at that.
That's a great point. Andy?
Well, I think, Savage Joy, the question is what to do, right? People are going to think about, what do we do? And, I think that I actually would want to contribute this. I don't know if it'll help the conversation, but you know, we've been told again and again and again what we're allowed to demand when it comes to health reform. Some of the questions in the earlier panel were about the so-called public option. You know, the public option was this cynical game played by Democratic Party insiders to try to derail people who are demanding fundamental health reform in the run-up to the Obamacare. And their theory was that if you had a public private insurance company that competed on the market against the private insurance companies, it would somehow win the competition because people like the public product better than the private product. When the competition in insurance is to compete for the healthy and the wealthy patients, and the insurance companies are already geniuses at finding exactly the healthy and wealthy patients, therefore the public option would be predestined to attract needy and poor patients and not be economically viable as a policy. It was an unbelievably cynical ploy launched at an audience that believes in the magic of the marketplace for ideological, not any kind of understanding reasons. Then the president, who promised to abolish Medicare Advantage, the president who gave a speech at a labor meeting in Chicago in favor of single payer, set in motion a neoliberal policy process in which Liz Fowler came from the WellPoint, vice president of WellPoint for public policy, to be Max Baucus on the Senate committee. I think it was the Judicial Committee who had to master getting the thing through. So you basically literally had a quote unquote reform written by the insurance industry. And in the aftermath of that, because now we're a decade on, that reform, regrettably, and it's terrible. It invited in myriad middlemen, unbelievable conglomeration. My own community, there's a Catholic hospital chain of nearly 100 hospitals. I don't know if it's 70, 80, 90. I don't know the exact number of hospitals. Lots of hospitals, dozens upon dozens of hospitals. And I was at a community hospital where the foundation, the local community foundation, the fundraising people who had bake sales for the poor of the community, so that when someone from the homeless shelter had a special need, you could tap that community hospital foundation, that charitable arm. They voted themselves out of existence in the corporate takeover. So their fundraising, their modest community-based fundraising for the poor of their own community became part of the corporate conglomerate, that chain that owned dozens upon dozens of hospitals, that wears its Catholic ethics on its sleeve. It's just shocking to me, really, that this kind of conglomeration was sweeping through. But the Affordable Care Act made it possible. And then the profitizing, as Karen reminds me, not to call it privatizing. The profitizing of Medicare. The Medicare Advantage program has grown greatly. Every state now hires private insurers to manage their Medicaid program. It's an amazing statistic to think that private insurers, who once got most of their income from private employers covering private employees, they now get most of their income from governments, from states in managing Medicaid, and in the federal government through Medicare Advantage. That's how they're making their money. It's a first pass metabolism of the money through the private insurer, to use a medical liver analogy. It's just a kind of a crazy policy to guarantee the profits of a private corporation. And so if we talk about a single payer, I'm going to go out of bounds here. Dialysis in the United States of America qualifies you for Medicare. All end-stage renal disease patients get Medicare. If you get dialysis in the United States, chances are you get it either at a company-owned dialysis center owned by Fresenius or a dialysis center owned by DaVita. Two big, publicly traded, for-profit dialysis companies, and their income comes from Medicare. We have a single payer for dialysis patients, and the majority of patients are seen by two monopolies. There are very few not-for-profits.
So the reality is that 95% of dialysis centers in the United States are for profit. And the biggest problem with that, it's a majority of physicians, the majority of nephrologists who work at those systems profit from the system, right? They get profit sharing from the companies for which they work. And that is why the United States has such a low transplant rate, because the physicians responsible for referring those patients for dialysis profit from dialysis and therefore have less incentive to refer people for transplant. You know, in Canada, the plan is to start you on dialysis while they get you well enough and strong enough to get your transplant. And we don't do that. And people ask, why do we allow so many people to die on dialysis every year and refer so few of them for transplant? It's a profit-driven motive. I mean, that's a reality. That's the world in which we live in. And I think that we have to acknowledge that we're spending, you know, trillions of dollars, literally trillions of dollars, and not acting in the best interest of the people who are receiving the care, or even offering them the best care that's available.
Andy, did you want to respond?
Well, Claudia is making the point. I think that we should focus on the outcomes, not on specific policy. And I think that we should have a very, very careful approach to our friends who tell us what we're allowed to demand. For example, a state-based quote unquote single payer, or a little bit of Medicaid expansion, or a little bit of Medicare for some more. I think that I'm in favor of incrementalism. I realize that the system needs to be changed incrementally, not all at once. You can't cause mayhem. You need to have some order. But I would say that the goal is to get the profit taking completely out. It needs to be a completely human service with no one making a profit. It must be a principle that no one makes a profit. It must be a principle that people do not pay out of their pocket when they need the care. These must be built into the system, or you will not end up with a humane system, and we will never get at the inequity, because we have so many disadvantaged people for so many reasons. Institutional racism, #1 in our country. But the point is that without getting our arms around having the money out of the system, there's no way we'll get to the next step of having planning for each and all.
Well, I think the problem is that we have allowed the politicians to dictate what the choices were. And they are not necessarily the...
There she goes.
Darn it. But yes, she is correct that we should not be taking orders from them. You know, we have 135 legislators who have signed on to Medicare for All. And what's going on? Nothing. They are absolutely celebrating the fact that, yes, let's lower Medicare to age 60. And those breadcrumbs are supposed to be celebrated, and not just does lowering it 5 years not change everyone's life, it also doesn't help with the many inequities that are in regular Medicare. So yeah, you're all absolutely right as far as the incrementalism. Karen, did you want to add on that as well?
You know, I am reflecting on the time that goes into thinking about this and the amount of space this takes up in people's lives as they try to navigate and manipulate the system in ways that will at least try to work for them. And, you know, it is just not, I mean, I spend my days thinking about how to make healthcare systems better, but how to pay for basic hospital and physician services is not something that I think about ever. When I moved back to Canada, I would stop at the desk at the doctor's office and look at them getting ready to pay, because I had been paying in the United States for 2 decades. And they would sort of look up and say, yes. I'd say, oh, right, okay, great, thanks, bye. Because, you know, it took me a long time to drop that habit of stopping to pay. And it's just not something that consumes the lives and undermines the lives of people in most developed countries around the world. And it is just so odd that it still continues to do that. And as I'm hearing on this call, and I'm reminded of, you know, what that felt like, it's something that is far from my mind and from the minds of most Canadians who live here, who don't have to worry about whether they're going to go bankrupt if they go to the hospital.
Absolutely. Andy, do we have any questions from the audience?
We sure do.
All right.
Now, I've been getting them secondhand because of the way that we're streaming. They're not coming into the chat, but you've all met Virginia already in the green room. She's been sending me the questions that she's been seeing in those chats, and so there's a few of them, and I think there's a couple of good questions here, and they're more, I think, from Americans that aren't familiar with certain aspects of the Canadian system. So if
here we go.
yeah, and now they're not. I don't think they're as ludicrous as they usually are, but this one, there's a few here, and there was certainly one that Virginia asked me to ask for sure because she wonders about this. But there's a question from a gentleman named David McClanahan, and I
know David's question. He's going to ask about capitation, right?
Okay, all right. So you know this question already.
That's just too. I think it's too complicated and in the weeds for right now. I know there's capitation in Ontario's healthcare system. I know it less well than the other ones, and I'm happy to answer his question offline. I don't think it's. I think it's a bit in the weeds for this conversation.
All right. Okay.
Wait, I can answer that.
Okay.
There's no good way to pay a doctor. There's no good way to pay a doctor. You can pay a doctor by the hour, and doctors can subvert any system.
Well, so that's what I was saying before. You know, they say fee-for-service encourages excess care, which is dangerous, and capitation discourages, encourages underutilization. If the notion is that the dollars that aren't spent in delivering care are kept in profit. You know, the system where I work at a county where I have 1,000 physicians, we are salaried. And they say that with salaried, you're not motivated necessarily to do the best. But, you know, my question is, why are you in medicine, right? You know, there are a lot easier ways to make a living. We actually have certain expectations of our physicians, and it's not in terms of productivity. But did you talk to your smokers about stopping smoking? Did you make sure your women got their mammograms, that they got their pap smears, that your people over 50 got their colonoscopies, or if they had cancer? You know, so you try to give people guidelines to encourage them. But Andy's absolutely right. There's no perfect way in which to compensate people for the work they do, but you try to, because it used to be that people went into medicine or they wanted to be a doctor or a lawyer because those were the most lucrative salaries in the United States. You know, now you can go into business and you can go into a lot of gig economies. There are a lot easier ways to make a buck. And so we have more people who are into medicine because it's a calling or something that they choose to do. But I think that we could spend a lot of time saying what's wrong with a particular compensation instead of looking at how we make sure we deliver the best care to the most people.
And just to clarify, most doctors in Canada are still paid fee for service, but there's a big movement, especially in primary care, from doctors who don't want to be paid that way anymore and want to be paid salary. You know, they just don't want to have to, in a sense, churn patients in the way that you have to churn patients to make a living when you're paid fee for service. And I think the quote is actually Steffi's quote. Dr. Woolhandler, I think, as I quote her, says, "There are many ways to pay doctors. Some ways are better than others. There are no good ways." And that would be true for how we pay all of us. You know, payment in general, wages, earnings, salary, income, consult, whatever it is. They're, you know, they all have.
Do,
yes,
right?
Regardless of what you do, there are upsides and downsides to all of that.
Absolutely. Andy, do you have another question from the audience?
Here's another one that is more about how the healthcare system in Canada was rolled out province by province. And Virginia wanted to ask the panelists about if the provinces have the purview of healthcare in Canada per province, and there are different wealth levels to different provinces, and they all have slight differences. How do you deal with the inequity of outcomes?
There are equalization payments. There are wealthier provinces and poorer provinces. This is a fight in sometimes with the province of Alberta, which has historically had the oil and gas industry and has been one of the wealthier provinces. And anyways, there are equalization payments to oftentimes the maritime provinces over time, because they have been the less wealthy provinces over time. I mean, but generally, you know, the Canada Health Act ties the whole system together in that, in exchange for the federal transfer payment, your fair share of that, each province has to provide all medically necessary and hospital and physician services. So it's not as if the poor provinces don't have those things. They must cover those things in order to get the federal transfer payments. And they do.
And so if you're an American activist, you should not think that translating that to Vermont and Mississippi in 2022 makes any sense at all, because it's a federal system.
Absolutely.
Yeah, I mean, constitutionally, healthcare is the jurisdiction of the provinces in Canada. That is why it unfolded the way it unfolded. And so in the division of powers, you know, hospitals and therefore healthcare, you know, 100 years ago became the jurisdiction of the provinces, not the federal government, who only, you know, only is responsible for planning and you know, just distribution of the federal transfer payments to the provinces so that the provinces can deliver the care.
And Andy, I think we have time for one more.
Well, this one is a very simple question, and it's I promised myself I wouldn't answer it, but the question is healthcare possible under capitalism? And I'm not gonna.
This is gonna go till 3 a.m.
It'll go longer if I weighed in, but I'm not gonna say anything.
So I actually think the question is, I'd like to rephrase it. I think the question is health possible? Because healthcare is absolutely possible if you define it as access to an ICU or something. And there's a lot of wealthy nations where if you need an ICU, you get into an ICU. If you need an emergency room, it's there for you. Healthcare, the delivery of, you know, of a provider can be accessible to you. That's if you define it that narrowly, then absolutely. But you know, I think that the question is, do the people in charge of this system, which is obviously a capitalist system, own up to their responsibility for the health of everyone? Because that's the question of the modern society, is whether or not we can basically be safe and sound in order to be, therefore, some kind of idea of free. I mean, I think it's a precondition. I think that it's a big question. And of course, if you look at the corrosive effects of many of the jobs and such, you could say that, well, healthcare is inimical with capitalism, but you might also say maybe health itself. You know, who wants to work 5 days a week in a time when we could work 3 days a week? You know, these kinds of ideas. I think we're in a really tough time for trying to navigate the ideology, if you will. I think the old-fashioned indictment of capitalism holds up pretty well, but it's not the time anymore of other socialist examples that make sense to people. Right now, we have an inter-imperial rivalry fighting for the turf of Ukraine. It's kind of this unbelievable World War I craziness. We also have neo-fascists and a kind of a post-truth moment. So I think that these kinds of questions about the ideology, whether we're anti-capitalist, I think it gets to be very, very murky. And what I would point to for the reform for the health of each and all, and the idea of health equity, the idea of eradicating justice, which is a very big dream when it comes to health services, I think these things have social science measures which we can use as guides. Maternal mortality in the United States, for example, is a damning statistic, and we need the people that are running the society to put the resources in a way that will reduce maternal mortality. And we have a big dream that we could have the best possible care for all, because we have so many resources in the system, as we've heard tonight over and over again. There's no excuse for us not doing a beautiful and dignified job for every one of our patients at every presentation. And it's keeping that alive. I think that builds a movement. And I would just say one more time, it's going to take a movement of millions upon millions of people if we're going to win this progress. It's an organizing job, person to person to person. It's a big job, and it's doable.
Claudia, would you like to expand on that as well?
Yeah, I think the most important thing that finishing with Andy is doable. We tend to think that, so this is a social justice movement, and people fail when we don't think about that, And earlier I was talking about we allow the politicians to be in charge. Politicians have never led in any social justice movement in this country, or for that matter, in most other parts of the world. What they are focused on is getting reelected. And if you get a parade going, they're going to run to the front to be out in front, but they are not going to be the ones who started. And so I think that as soon as we can get the public to think about that this is a movement that will come, the public will dictate this to the politicians. We will mobilize, as we have for other movements, that when people are mobilized and activated, when people are in the streets, when people are daily demanding, that is when we will see change, and it will come rapidly at that point. But it is not until that's when politicians become afraid, when they see a loss of control, when they see masses of people demanding and they don't have a quick and easy answer. And yet that is when we are most effective in affecting social change in this country, whether it was ending a war, or whether it is providing voting rights, or whether it is providing access to education. We are most effective when we are angry, when we are in the streets, when we are standing shoulder to shoulder, demanding that to which we are entitled. And I think that if people begin to think about improved Medicare for all as a social justice movement, we can do that. We have done it time and time again. And it is old-fashioned activism that when we are most successful and effective. I'll stop there.
Karen,
the only other thing we can do would be to shout everybody in and nobody out, right?
Yes, absolutely. Karen, did you want to share any last thoughts as well?
Just that it's, the rest of the world needs the United States to do this, you know, because the rest of the world, the movement for universal health coverage or universal health care, you know, is in many countries. And so, you know, countries are looking to try and win this in places where it doesn't exist, and in countries that have it, hoping to hold on to it. And, you know, the United States has historically been, you know, a powerful and influential country, and, you know, and remains so. And so I think that, you know, the rest of the world looks to the United States to get cracking, you know, and make this happen.
Absolutely. So before we go, I definitely want to go around, and if you have a Twitter, email, website, anything you want to give people, anything, any way you want people to contact you, or anything you'd like to promote. So we'll go around in this circle. Dr. Claudia?
You know, I'm trying. Oh, yes. So I'm at one for single payer on Twitter. I'm really bad. I had to go look up my Twitter handle. But one for single payer is at ONE, then the number 4, and then single payer. Because I'm going to keep saying that until we get there. And I know we know that that's if you ask people about single payer, they won't know what that is. But if we say improve Medicare for all, they will. But I'm going to keep fighting for that one for single payer. Thank you.
Thank you so much for joining us. Karen?
I'm at Karen Palmer, Palmer, YVR. YVR is the airplane code for Vancouver. So at Karen Palmer YVR on Twitter, and happy to hear from you.
Awesome. Thank you as well. And Dr. Coates?
No, I'm not on Twitter.
We're going to work on that this weekend.
In 2021, no. Trisha Greenhall notwithstanding, 2021 I worked all but 9 days, and literally I worked 7 days a week. I'm going to try to be a better activist in 2022.
Awesome.
Any messages that are forwarded, I'll be glad to entertain. But I thank you so much for this.
Thank all three of you.
All.
This has been amazing. This first night really set a good precedent for the next 2 days. This has been amazing. Shout out to Anna, who scheduled everyone tonight. It's amazing that all of you have known each other for decades as well, so you can play well off of each other. We cannot thank you enough. This has been incredible. We've learned a lot, which is the most important thing. So again, just thank you so much. We appreciate you sharing everything with us tonight.
You're welcome. Thanks for letting me spend the Friday night with my friends.
Yeah. Good to see you, Karen. Even though you couldn't see me.
I see you, Claudia.
Thank you so much. And everybody stick around. We still have more. But thank you so much, everyone. We appreciate this.
Take care.
Thank you.